So I'm very happy to have you, James. Thank you.
Oh, no, thanks for inviting me.
I think first of all, our listeners would be curious to know how did it start this interest about psychotherapy research and practice, and how did it eventually lead to you being drawn towards psychotherapy integration?
Mhm. Um, well, I mean, I would say that those two are linked because I really went into my graduate training at Penn State. I worked with Louis Castonguay, and his work in integration was one of the main drivers of my interest. And so when I was in an undergraduate program, I was actually originally a biochemistry major
Uh-huh.
and was very interested in the scientific process and had every intention to go to medical school, but to primarily be a researcher. And then took a general education and requirement psychology course and really fell in love with it and the idea of, and it seems obvious now, but really thinking about human behavior and relationships from a scientific perspective to try to understand the nature of behavior and how that changes over time or doesn't change. And through my coursework, I also did some coursework in philosophy, thinking, being exposed to different models related to epistemology and even some philosophy of science, and then certainly other models of psychotherapy. And I was fortunate to actually have an instructor at my college who was pretty open about going through the different models. I think sometimes you run into a trap where somebody might disparage a certain model, and I won't go into detail about that, but be open. And so, it just really got me thinking that, well, these different approaches, whether it be humanistic, psychodynamic, or behavioral, it's similar to the I think, what do they call it, the medical school syndrome, where you learn about all of these diseases and you believe that you have them. You have a normal psychology course and you believe that you have that disorder. Well, read through these different models of therapy and you really think that, well, they are capturing something about the experience that seems on target.
Mhm.
Whether or not you're focusing on emotional experiencing or the function of different behaviors and unconscious meaning.
Mhm.
It speaks to, I think, parts parts of sort of humanity and functioning that are appealing and interesting and have some empirical support behind them, of course. And so, I was really driven by the thought that, maybe there's something that's common among these things that really is the best way to sort of account or explain these phenomenon and change in psychotherapy. Or maybe if there aren't these common factors, there could be something about these individual models that appeal more to particular individuals. So it
Mhm.
gets at some of that personalization.
Yeah.
So I've always had an interest in the idea of personalization, but then also at a very sort of theoretical level, how these different models actually operate and where they converge or diverge.
Uh-huh.
So from the beginning, I was very interested in psychotherapy integration and psychotherapy process research to study these questions.
Yeah.
So that's what led me to my graduate training.
Well, you mentioned one of your mentors, so Louis Castonguay. I'm sure that your interest in philosophy of science had a particular impact also in the way you viewed this model fight that sometimes goes on in our field.
Yes.
Was there also any particular book or author that also inspired you in any way towards this path, besides Louis?
Well, I mean, I think the main article that comes to mind would be Marv Goldfried's 1980 article on principles of change, which was published in American Psychologist, and that's really, I read it 100 times. Was really eye-opening to me because certainly I wasn't exposed to that initially in my training prior to coming to graduate school, and being in Louis' lab and Mark Goldfried being Louis' own mentor at Stony Brook, getting some early exposure to that paper and that model of thinking, that was really it was really exciting to read that, to think about this, this level of abstraction problem. And it's something that actually, I will admit that to this day, I still wrestle with quite a bit. You know, I think I understand it, but then I think about it a little bit more, and I talk with people, and I'm not sure that I totally understand it. And I actually teach an advanced undergraduate course on psychotherapy models and research. And I actually try to weave in this principles argument in some papers throughout that course. And then I tell students that this is going to seem unapproachable at the beginning, but as we continue to talk about it, maybe it'll start to make sense, and maybe you can help me make more sense of it. But I do think that there's something really important at a basic level, not just from a research perspective, but certainly from a clinical perspective, and thinking about what are the specific behaviors and interventions that we're engaging in versus these broad theoretical models that we're working from, and sort of how to understand phenomenon and what we think about is important for change. And then that level in between around, well, what is, when it comes, and it's really more of a dyadic and intra-psychological process in terms of corrective experiences, developing a positive therapeutic relationship, providing feedback. It seems like that really is the level where the action's happening, and particularly around psychotherapy integration, where these different models we might be able to actually converge at that level too. And so that's certainly an article that sticks out for me, and I continue to cite it pretty liberally.
I was going to say, in the back of my mind, I was thinking of that article, because when I read your articles, you always like to put that one in. It's a personal favorite, I can see. It's
not a coincidence, because it's not in, I don't know, maybe I'll have to think about it more, but it doesn't feel as though I'm forcing it. It feels like it's natural, and to bring it into the conversation, especially when we're talking about integration. And we're talking about mechanisms, and trying to think about the difference between, say, an intervention mechanism versus what we tend to, I think, often think about mechanisms in terms of what's happening within the client that is changing, which is slightly different from whether or not this particular intervention is correlated with that process.
What I think is really interesting about your work is that you really try to focus on different levels of approaching the research. And I know that you're also very big into process research. So, and we'll touch on that a little. But before jumping into that, I'd still like to ask you, because in this recent paper, you wrote that an integrative approach has and will continue to be the leading edge of psychotherapy research, practice, and training. And just for our listeners, I think that the idea of psychotherapy integration maybe has changed along the way, because a lot of people before maybe have thought that it's just the integration of different schools of therapy, but throughout time it seems that we're doing different kinds of integration with different fields. Would you mind commenting on that?
Well, I mean, certainly there are different, pathways to psychotherapy integration, and the way that I tend to think about these things is specific to assimilative integration. So working from a primary framework, but then, as Stan Messer and others have described, sort of bringing in concepts and even technical factors that are more closely connected to an alternative or exogenous theoretical orientation. And partly why I wrote that paper and framed it that way was that I think if you step back and you look at the developments in psychotherapy in over the past decade, and if you look at, or a couple of decades, and if you look at where, say, for example, the National Institute of Mental Health is going in the United States with its focus on these RDoC categories and systems, moving away from moving toward a transdiagnostic way of thinking about problems, that it's offering a way to think about these things at that abstract level, or that intermediate level that I mentioned. And so this actually links back to what I was mentioning before, is that these processes are, just by their nature, often cutting across different theoretical models. Now, the more we learn about these processes, whether it be interpersonal systems, affective systems, biological systems. Of course, these things are, they're all related dynamically, but if we sort of divide these things up, right, that we really are talking about an intermediate level of abstraction that it would be hard to find somebody who even primarily identifies with, say, a psychodynamic orientation or process experiential orientation or a behavioral orientation. It's most people when they're asked about it, I think yeah, that makes sense to me, and I can see where we can actually have a conversation around those things. And something else that seems apparent to me is that if you take, for example, cognitive behavioral therapy, and so I, even though I'm very much an integrationist, my primary framework for thinking about things is cognitive behavioral, and a lot of the research that I've done has been specifically in cognitive behavioral therapy or some version of cognitive behavioral therapy that integrates some other component with an emotion-focused component or interpersonal component. So if you look at where CBT models, how they've evolved, and then you look at these quote-unquote third wave therapies, dialectical behavior therapy, acceptance commitment therapy, it's pretty striking that we're really talking about integrative therapies. And you could make an argument that these are assimilative therapies, that they're working primarily from a CBT perspective, but they're integrating whether it be mindfulness or emotion-focused theory and interventions, a number of other things. Certainly, there are psychodynamic components to a lot of these treatments too. But I just think that as the research has accumulated and these treatments have developed, I think we've almost by default ended up with the state of the art being integrative treatments.
Yeah.
And I don't think that it's a coincidence that at the same time, the focus of the research and the funding climate is really moving toward these systems and factors that cut across different levels of functioning, aspects of functioning that for many decades were tended to be ascribed to one particular model, and I think those barriers are being broken down. And so I think it's a more of a professional, conceptual question. Are people, for whatever, or political question, are people open to calling these things what they are, integrative therapy, and what precisely are we integrating, or for whatever reason there's some aversion to calling it what it is. There may be some political factor in that, but I think if you just look at objectively what's happening in the field, I think that it's pretty clear that we're talking about integration, whether or not we label it that way.
Yeah, you touched on the topic of transdiagnostic, and I'd still like to ask you also about that, because you have, for a long time in your career, I think, released some papers also on this. You did a paper on intolerance of uncertainty as a common target, transdiagnostic target, and transdiagnostic CBT. And I was wondering if you think that this transdiagnostic research and their findings, if they just add to our knowledge of psychopathology, for instance, or if they in a way put question marks on the validity of some of our models, because if some of these targets actually are transdiagnostic in a way, then it could indicate that some of our categories are, I don't know what good word to use it, but can you understand my question? Yeah.
Yeah, and I think this is an ongoing debate, and it's a good one, because even though I've been doing some work on transdiagnostic therapy and in one particular type of transdiagnostic therapy, the unified protocol, which speaks to me because it is broadly CBT based, but also I would say that just naturally I gravitate toward an emotion-focused orientation. That would be kind of my A, sub A or B orientation. And so it's emotion-focused, in the same way that many have argued that, really the working with emotion and emotion science is one of the bridges that's really critical. I know Les Greenberg and Mark Goldfried have written about this. That can be a pretty key bridge across the different models that we have. If you look at the literature, and it's of course always evolving and somewhat mixed, but to say that a transdiagnostic approach is useful or or providing important incremental information about psychopathology and treatment is not to disregard that there are some pretty important differences among problem areas, systems, whatever that might be. So to say that there are some constructs and mechanisms that are similar or converge between, say, anxiety and mood disorders as currently defined in, say, the DSM, is not to say that there may not be some, certain things that are unique about say, major depressive disorder compared to panic disorder. And so, I think that's important to just be clear on. Is that it's not dismissing that there may be some pretty critical differences that will have real implications for treatment, for example. But from a therapy and sort of from an understanding how change takes place, perspective, if it is the case that these, going back to the RDoC in some ways, these systems or these constructs do appear to cut across these traditional DSM categories, you start to have to wonder what really is the usefulness, of these. If these constructs and these systems themselves become to define the problem, then these fine-grained categories, this categorical system starts to be less useful. So I tend to be a pragmatist. I want to look at the evidence, but I'm also a pragmatist and think, well, what, if for uncertainty, for example, and I like these, and just like common factors, depending on what you read, there could be a list that identifies 10 of these factors, or you could see a list that has 100 factors. So whether or not something is transdiagnostic, there are a lot of different constructs out there that can be transdiagnostic. But it is kind of going back to the future in some ways. It's identifying, psychological experiences, constructs, behavioral patterns, and targeting those in therapy rather than targeting symptoms. So if you think about, if you have somebody who comes in with primary panic disorder, wants help with their panic, but they also experience low mood from time to time, they also engage in a fair bit of excessive worry, these things tend to co-occur at a high level. If I'm approaching the problem as panic disorder primarily, and thinking about, if I was to tell myself or a supervisee, the goal in this treatment, given the panic, is that you really want to target those panic symptoms. So this treatment is all about reducing panic levels, reducing anxiety levels, and so go do that. It's not very helpful, but if I can say, we have the panic attacks are the primary problem. We do need to address those, but we also have issues related to mood. We also have issues related to this unproductive ruminative process. What are some factors that cut across those things? Well, we look at something like anxiety sensitivity. So there are a number of interventions we might use to address anxiety sensitivity, which tends to be elevated for people with panic, but we've also found that it's elevated in other anxiety disorders and also eating disorders and smoking, et cetera. And so we can actually work around how to address anxiety sensitivity. That makes sense. And if we address that, then if it has some sort of a linchpin effect, then it should also be having some impact on the worry processing and even mood to a certain extent. And so, there's the nosology problem that I think many people, are aware of and have been critical of this excessive parsing, And so to say that something is transdiagnostic doesn't mean that there aren't important differences, but it's clear that there are potentially better ways of thinking about functioning and dysfunction. And for me, they make much more sense clinically. And so as a clinician, I find it very useful to move away from those sort of hair-splitting distinctions and thinking about things more dimensionally and thinking about them more at that system or construct level, because it just seems more intuitive to me. And my hunch is that it's also really don't have a lot of data to show this, but my hunch is that it's also experienced by the client as being much more validating. Mm-hmm. I think that there's something about the rationale that this is a symptom problem. It's defined in this particular way. We're applying this label versus the person as a whole, and sort of thinking about how we respond to our emotions and whether or not that's helping us or getting in the way, and how that's connected to rumination and how that's connected to behavioral avoidance. It's much more experience near. Like I said, I don't have any data to show that it's experienced as more validating by the client, but I have a hunch that it might be.
It's an interesting hypothesis, this idea that maybe talking about processes is inherently felt as more nicer, in a way, more validating than talking about disorders, for instance.
Right.
It would be a good research study to do in the future also.
Yes.
How did because when you research, like you said, you do it from a CBT framework, but you even call it sometimes an emotion-focused cognitive behavioral intervention. So historically CBT has done a lot of down-regulating of emotions. And you've also written about how this other tradition, in a way, talks about heightening of emotions. I remember even Louis Castonguay and Marv Goffrey doing those studies that they found out in CBT that when you heighten emotion, it was better for outcomes. So how do you deal with this conflict that has been going on within the CBT tradition of upregulating or downregulating emotion?
Right. Well, I mean, I think that there's a...
Sorry, just to confirm something. So we're talking here, this is a trick question in the sense that I'm connecting here with clinical decision-making. So... I'd like to ask, what would be the marker to know when to do what, in a way?
Oh, interesting. Yeah, I mean, I think that there's a paradox at the functioning or pathology level that I think is mirrored at the intervention level too. With that, where and in some ways this notion that's attached to child or youth pathology and treatment around externalizing versus externalizing disorders and sort of are you in terms of dysregulation, is it overregulation in the sense that you're damping things down, about things like anxiety and depression typically, or is there some hyper sort of reactivity, where there's a lot of strong emotion, and part of the problem is actually that it's too intense and leading to strong emotion-driven behaviors that actually get people into trouble, right? And so, I mean, I don't think that we can approach this as you always want to ramp up the emotion versus you always want to control the emotion. I mean, the paradox is that at some level, we are talking about more adaptively regulating the emotion, which does imply some level of control. But what is the best approach for facilitating that in a way that's healthy, that enhances flexibility? And I really like this. I think more and more people are really honing in on this notion of flexibility in responding. And I actually had a supervisor when I was in graduate school who really talked about this quite a bit. Around that. People. You tend to be healthier if you tend to be open to your experience and accepting of your experience. And the more you can identify yourself as being flexible, that really is psychological health, is flexibility, right? And so, yes, I do think that, and somewhat unintentionally, that for non-exposure, and I'll put that aside, so non-exposure based cognitive therapies, there is the potential in some cases to not sufficiently allow for evoking of emotion, and not fully recognizing that this dampening of emotion or suppression, which could be from worry or rumination or some other behavioral avoidance or substance use, for example, is actually partly what's maintaining the problem. Right. And so I think that this emergence of integrative therapies, like the therapy that Michelle Newman, Tom Borkovic, Louis Cassaday developed this integrative therapy for generalized anxiety disorder. Paying attention to the basic psychopathology and treatment research, not throwing the baby out with the bathwater, saying that CBT is ineffective because it continues to be one of the more effective interventions, but to identify that, well, maybe one avenue to improving effectiveness and maybe reaching more individuals would be, let's recognize that in many cases this standard approach is unintentionally dampening that emotional expression and maintaining the very process that we're trying to address. Mm-hmm. And so maybe there are some alternative approaches for example, stop doing that, but better ways of evoking emotion, and it's an empirical question about whether or not that's actually going to be helpful. I guess what's tricky about your question, and I've punted a little bit on it, is that it really is going to depend. Because as I said before, I think that rigidity, inflexibility, suppression, dampening in general tend not to be very, very healthy. Mm-hmm. These tend to be things that are associated with a number of problem areas, whether they be mood, anxiety disorders, eating disorders, somatic symptom-related disorders, whole host of disorders. But that's not necessarily to say that your that therapy is maximized by always evoking intense emotion. I know that a lot of the work that the folks at York have done with Les Greenberg, Alberto Post, and others, looking at emotional processing in emotion-focused therapy for depression and generalized anxiety disorder. What's fascinating about that to me is and this is actually was a focus of my dissertation, was looking at the type and degree of emotional arousal, within treatment, in this particular case with generalized anxiety disorder. And sort of this notion that arousal for arousal's sake, that to some degree, maybe it'll explain a certain portion of the variance for particular types of clients, but it's too rigid. It's too rigid. It's somewhat meaningless out of context. Sure. There has to be, cognitive emotional processing. Yeah. There has to be meaning that is somehow evoked in relation to that arousal for it to really be helpful, and actually have an impact on the individual. Because, so there needs to be more than just the
heightening or dampening.
Yeah. There's more to it, certainly. But I do think that and I struggled a bit with this clinically, is that I think that there's a paradox around being over-controlled and its potential maintenance of emotion dysregulation. And we try to provide that rationale, which is pretty key in the unified protocol. You kind of think through that paradox with the client. But even, as a therapist, I'm trying to say we're increasing flexibility. We want to actually open you up to your experience. We want to work on that. But at the end of the day, aren't we really still talking about
control in any way?
Controlling.
It's a philosophical question also.
Right.
Like trying to achieve non-control through another type of control.
Yes.
It's tricky. Well, this bridges perfectly with what I have to say my personal favorite contribution from your work, which is the context-responsive psychotherapy integration. And one of the answers I think you proposed to this, and now you can show off your emotion-focused credentials, is trying to bring the marker-guided work into CBT or in transdiagnostic intervention in general. So just to tease you a little, because I know this is the title of one of your papers, how do you think that clinical errors might happen through a lack of context responsiveness?
A graduate student in my lab, Matteo Bugatti, and I, recently published a paper in Psychotherapy, and they had a special issue on errors, clinical errors, and because of the work that we've been doing with Mike Constantino, he's really the person who's fully developed this model and way of thinking about things, and it's very exciting to me, and sort of invited me along for the ride. And so we've been thinking about, I know he's been thinking a lot about, how do we, not just in terms of thinking about our psychotherapy process research, but also training research. Yeah. How do we actually start to apply and think about this model? And so, I mean, I think it really, and I'm sure this has come up in every single interview you've done, is that it really boils down to responsiveness.
Sure.
And so, I mean, I think that there are any number of markers that we might identify in a session, and it's really tricky to know, without more data, whether or not in your particular response in that moment is going to be problematic. As we were going through this case, for example, that we published for this special series, it's and I have to say it takes a lot of guts, for somebody to write this up. How I made some mistakes, and I think that it's helpful to realize that we all make these sorts of mistakes, and so. Obviously we need more research on these markers, but I think it's you're recreating this narrative in hindsight in a way, by when you're going back into your sessions, and this is why I think it's so important to record your sessions, in addition to collecting some routine data, and you can trace back sort of, like when the person started sharing that story about their interaction with their parents, and I was, because I'm a good little supervisee, I was so, I had a plan going into the session, and I knew that we needed to get to practice this particular mindfulness exercise.
So I cut him off.
But I really just, and I thought that I was doing a pretty good job, because I was listening, I was attentive, I was nodding, and I invited, the person to say a little bit more, but it seemed like maybe they wanted to, but it was enough of a, they gave enough of a green light for me to keep going on. And they did initially agree to this treatment plan. So this is collaborative, right? But you look back and you think, well, I missed something there. Like maybe that was a time to just sit with the client. Yeah. Maybe the right move would have been to do nothing. Yeah. To sit there and be with the person and let them naturally, continue on with sort of describing or connecting with what they're experiencing. And so, I mean, I think that these non-responsive errors happen all the time. And I think at a certain level, they're probably unavoidable. And yeah, so they can come up in any sort of shape, size, flavor. And
I like what you said about the emphasis of trying to record ourselves, to be honest, because it's again, your process methodology comes up here. But it's true that in hindsight, we really don't know a lot of what's happening. So that would be a shout out for us all to try to bring our tapes whenever possible. Right.
I mean, I think that some. And my hunch, is that, there's some basic interpersonal skill, in addition to knowledge that people are bringing into the clinical encounter, where you're better positioned and open to noticing these things. Mm-hmm. And so I think that over time, as we learn more and we consult more and think more and get a bigger sample of our own clients or supervisees' clients, then we start to notice these patterns. And hopefully we can study them rigorously, but there's also a wealth of clinical observation to bring to this, right? And so I think that we can, through various methods, come up with a way to better prospectively or in the moment identify these things. Yeah. But I think even the best therapists will miss things. Yeah. And so I think that it's bound to happen. I think we can enhance responsiveness, but I think responsiveness always has this there's a logical problem with it, in the sense that it can be difficult to tease apart process from outcome in a given moment. Because as a supervisor or as a trainer, as a researcher, I would like to be able to watch a session that my supervisee is having and see, like, wow, it seems like they're really, I think they've done a nice job here. I think that they're really, this is collaborative. They're experiencing with the client. They're delivering things in a skillful way. It seems like this is a good interaction. This seems to be very helpful. But then you might probe the client at the end of the session and ask, how helpful was this session, or what was most important about the session? And they tell you something completely unexpected, that it was horrible. And so how do you go back to, well, I think that the therapist was being very responsive. It's like, well, I would like to think that there are certain things that we do that sort of just at face value are good interventions or useful interventions or ways of responding. But at the end of the day, it's all sort of operationalized by the client's experience of it.
Sure.
And so I think I absolutely think, and I agree with Mike on this because I know he's mentioned this, is that I believe that we can study these processes. I think we can improve our treatments by doing so. I think we can become better trainers by doing so. But I think it's always going to be a little bit messy. And getting back to the uncertainty factor, there's always going to be a little bit of uncertainty. But I do think this context responsive approach based on markers, similar to the work that they've done in EFT, it just makes, again, I'm a pragmatist. It makes a lot of sense clinically for me. We just have to put in the work to better identify those markers and those patterns.
Changing a little bit, I know that this year the Society for Exploration of Psychotherapy Integration, they're going to have the conference in Denver in May. And I know that you're going to present a paper on therapist effects. And I'd be curious if you could give us a sneak peek of what is your own take on this issue.
Sure. So for that particular panel that we're doing, and Abe Wolf and Mark Goldfried, Franz Kaspar, Tim Anderson, they're also involved in the panel, and this is part of a book that's been edited by Louis Castengay and Clara Hill, on this issue of therapist effects. And so, what do we mean? How do we define a therapist effect? What do we know about the therapist effects, and what are the implications? And that was really our contribution. Mike Constantino and Louis, David Krause, and others, we've collaborated on a chapter really focusing in on those implications. And so, I think at a basic level, we're not talking about something that is all that controversial in my view, because I think that, quite naturally, right, I think it's, it would be difficult to find somebody if you ask them, do you think that there are differences between dentists? Do you think that there are differences between surgeons? Have you ever had an instructor who was particularly good or not so good, who was less helpful? That there's a distribution here. There's a normal distribution in terms of effectiveness being defined by, say, outcomes, symptom, functioning, well-being, quality of life outcomes, or behaviors. And so, pick your model and the set of interventions that tend to be associated with that model, whether or not somebody's able to actually, follow that framework in a consistent way that's useful. There are also going to be differences there. So I think the basic notion that there are likely to be differences between therapists is really not all that controversial. I think that it's, I think that in order to study it rigorously, it does require, a good amount of information. It does require relatively large samples of therapists, of clients, and then often repeated measurements. And so I think that where there's maybe it's almost the case that in my view, that the basic conjecture that these therapist differences are meaningful, they exist and they're meaningful, is not so controversial. I think people sometimes get wrapped up in the statistical piece of it, and think that maybe it's because it's so statistical, it's essentially an artifact, which is just not the case. But in our in our particular chapter in what we'll be presenting at CEPI, and I don't want to give it away.
Just a tease.
Yeah. So we're working from the perspective that these therapist differences do exist. They are meaningful. And we've done some recent work along with David Krause. We published a paper in Journal of Consulting Clinical Psychology where and this is actually indirectly supported by other research that's been published too by Bruce Wampold and others. But demonstrating that these relative therapist differences are stable over time. So a key question is, if we can identify what these differences are they stable? Do they have some predictive validity to them? Meaning that if we were to, identify somebody as being particularly effective for this problem area or in general, and we could throw in anything. We could say particularly good at developing a good working, a positive working alliance, whatever the construct of interest is. And it seems like in what we're defining as a critical mass of clients, we've established this. Does it hold up if we look at a subsequent sample, right? Mm-hmm. And so essentially that's what we found is that there was a high degree of correlation.
Consistency.
Consistency over time in terms of the average effectiveness in a caseload for certain types of therapists. And it's also important to note too that in doing this work, we've done a pretty deep dive into health services research in the public health world too. Talking about they're wrestling with the same issues when it comes to physicians. Yeah. Physicians and differences between hospitals and how do you make use of this information in a way that's fair and useful, right? And so when you think about, well, if it is the case that these differences are meaningful and that they're valid, mm-hmm. How do you, what's the next step? And what are the implications of that aren't going to unfairly, unfairly punish therapists? But then also, I think the real potential implication of getting it wrong is that the idea would be that if we can harness therapist information, performance, in any category you might prioritize, if we're getting it wrong, then the clients aren't going to benefit. I think that the idea is that we want to make sure that we're identifying, the right information and we're doing it in a rigorous way that has validity to it, that has consistency to it, because that's the only way in which it's going to actually result in better outcomes. Yeah. And I guess I'm putting the cart before the horse a little bit because that's one place where we focus our attention in that chapter and in the talk will be, if these differences exist, if they're stable, then we need to really start thinking hard about what the implications are. Especially if there is, and Zach Emmel's done some work doing some simulation studies to show, like over time at more of a population level, what are the real implications of therapists who are consistently demonstrating negative outcomes? Mm-hmm. I think that we're past due for having discussions about, well, what are we going to do with this information? Mm-hmm. And I think that it's, there are some general themes in what we will be talking about too that are critical because this is complex. One theme is that we want to be able to account for patient differences because this notion of risk adjustment is really important. You want to be able to compare apples and apples, not apples and oranges, right? When you're making these decisions. Another reality is that most of what we know is based on routine outcome data, really focused on symptoms and functioning, well-being. Are those the best things to be focusing on? Are there other constructs? Are there other types of outcomes that we should be prioritizing equally? And getting back to the discussion about integration, there are certain models that will prioritize symptom reduction over others. And so even within particular models, are there certain types of outcomes or processes that we would want to prioritize when we're thinking about relative therapist effectiveness, impact, and then the other theme is that we, this is necessarily a multiple stakeholder problem. And we like to think about it, as though we're as psychotherapists ourselves and psychotherapy researchers. I think it's important for us to quote unquote get ahead of the potential policy implications that may be instituted by systems, individuals, without sufficient background knowledge or information. And I think in general, at least in the United States, there is this tendency to push policy ahead of really rigorously testing that policy. And so it's really important for us, as therapists, as researchers, including patients, including healthcare system broadly, that everybody be involved in these discussions. And so we're really thinking about the different implications of that information, coming up with better methods for actually measuring these things, analyzing these things, but also the very practical implications of what do we do with that.
It connects beautifully with your interest in how to best implement the research into practice in a way.
Absolutely.
And so, since we're drawing to a close, I would be curious still to ask you, what are you working on now? What's exciting to you now?
That's a good question. So my lab here, we're actually involved in a lot of different things, we are presently doing several process-related studies that I won't go into, but we've continued to, and this has been the case in my career, is that I've had these two paths that occasionally will intersect, but not necessarily intersect. And one is the more traditional psychotherapy process outcome research, and then the other has really been this more systems level routine outcome monitoring work related to the therapist effects and decision making at more of that systems level. And frankly, in recent years, that's when I'm not sleeping at night or on a run trying to come up with some ideas. It's my brain is more fixated on the systems level work right now. So we just completed a study that was funded by the Robert Wood Johnson Foundation here, where we took this issue of therapist performance and looking at other areas of healthcare where they actually are, say, publishing hospital rankings and surgeon rankings and sort of this direct-to-consumer publishing of performance information. And the research is very mixed in healthcare generally. It's not clear that it actually contributes to better client outcomes. And went to identified patients themselves to ask them, so this is happening right now. and health systems are actually wanting to move on this notion of quality assessment and performance assessment. And let's assume that we have these provider level report cards in addition to other types of information about your treatment. What are your attitudes toward that information? So if you showed up at your community mental health center and rather than just get assigned to again, I'm talking about the United States here, rather than just get assigned to the next therapist who's available on a Tuesday, which happens to work best for you, is there a more informed way of directing you towards somebody who would be a better fit? And better fit, of course, talks about preferences, which are always going to be multidimensional. But we wanted to get at general attitudes toward performance information, and then also compare performance information to other characteristics of therapists or treatment factors. And Bruce Wampold actually brought an article to my attention that was published in the Journal of Counseling Psychology back in, I think, early 90s, where they did a really elegant experiment where they manipulated it was actually focused on sex roles, but where they manipulated information about different types of therapists. And they were interested in whether or not you were more masculine or feminine on these dimensions, given this vignette about a particular therapist, would you be more likely to choose a female therapist or a male therapist or a stereotypically masculine therapist or feminine therapist? But their sort of control comparison was that they would vary the effectiveness of the therapist. And so you had that being different throughout. And the only consistent finding that they had was that people in general always preferred the more effective therapist. So we're getting at some of that, so if you could see a therapist who's been demonstrated to be very, to work really well with individuals who are primarily depressed, which is the problem area that you're coming in, we could assign you to that person, or we could assign you to somebody who's of the same gender, or the same ethnic background, or who costs less. And so we're actually just analyzing the data right now. And so we ended up with we're using a survey methodology in addition to semi-structured interviews that we're analyzing qualitatively. We also conducted a number of focus groups, and these are all community mental health center patients in the Northeast U.S. But we're hoping to get a better sense of what do the clients themselves make of this therapist performance information? Do they value it? Similar to the Wampold results, would they sort of, relatively speaking, place more value on performance information compared to other characteristics of the treatment? And that actually leads right into a randomized clinical trial that we're doing right now with Mike Constantino. Is the prime principal investigator, and I'm a co-PI on the grant, along with David Krause at Outcome Referrals. And what we're actually doing is we're testing this hypothesis that if patients seem to value, and all the data that we've collected, we're still analyzing it, but the message is pretty clear. The clients want access to this information. They want to know that it's being used at some level in their care decision making. That's pretty. And so if clients value it and they believe that it would be helpful to them, and we can identify these relatively stable differences between providers at a systems level, what is the potential comparative effectiveness of randomizing people to see a predetermined, well-matched therapist versus a therapist at somewhat at random? So basically based on routine administrative practice, which tends to be who's available on a Tuesday. And so that study is underway, and so stay tuned for those results. But so this is just a long way of saying that I, in conducting this research and speaking more with clients, and the clients that we're focusing on here tend to be the pretty under-resourced individuals. They tend to not have a lot of power or control or agency when it comes to their therapy. They tend to be, their voices tend to be silent in the published literature. The more I'm convinced that from a public health perspective, at least in the United States, we can really do a lot, I think, to improve the systems by engaging in this practice-oriented research, doing it in a way that's collaborative, that prizes the patient's perspective, and developing better methods for harnessing this vast amount of information that we're collecting. What do we do with that information? And working together to use it in a way that's actually going to benefit, individual clients, but then also at a population level will also benefit communities. And so, I'm moving much more at a macro level.
But one trend is clearly the giving away some control to the client itself. It's actually reminding me a little bit of the recent interests of John Norcross, also focusing on client preferences and matching to client characteristics. And I'm really happy that you're trying to think of it also at the systems level, because it does seem that if no one does that, then it's the policy who implements these kind of decisions. So.
And it's also it's another one of these, I don't know if it's a paradox, but it's another, the irony is that in order to maximize personalization, it requires examining things at these different levels,
Sure.
including at the nervous systems level.
Yeah.
Um,
Including studying the responsiveness.
yes.
Yeah.
Yes. Yeah.
Well, James, I'd like to finish off with one last question I've been asking all of our colleagues, which is basically, what advice would you wish to have received when you were starting out your career as a researcher and therapist?
Wish to have received. It's a good question. I mean, I think that maybe I'll work around to it without just blabbing on and actually answer a slightly different question, which is, I think that potentially the most useful piece of advice that I've received was to never give up or get too demoralized. Mm-hmm. And I'm talking primarily from a research perspective here.
Okay.
That publishing is difficult. You will get hard feedback. People sometimes be critical. Not every grant, in fact, the vast majority of your grant applications will not be funded. Take that feedback in the way that it's intended. Spend the next 48 hours, if it's a grant that's really important to you, maybe the next 2 weeks, screaming and cursing and becoming somewhat, depressed. But then go back to it and
gracefully applying the feedback.
Well, usually when you come back to it, once you've cooled down, the feedback is useful. Yeah. They can actually see that there's something valuable about it. And so, yeah, I think that's been really important to me, is to just not, science it's incremental, it's slow. Don't get sort of discouraged. Don't So don't let these things sort of get you down. Just keep working and trying to solve the problems that you value, that you think are important.
It's actually very useful advice for the clinical setting, also, including the harsh feedback we might get from a client.
Yeah, absolutely. From a client, and potentially from a supervisor. I mean, I think, feedback in general, again, it comes somewhat full circle, because, the outcome monitoring and the performance information that we're collecting and researching, it does come back to comes down to feedback.
Yeah.
Are you able to, take in information, and make use of it, assimilation, accommodation.
The classic.
Don't get worked up about the thing that's potentially unfair, or but take what's useful from it and move forward. And I mean, beyond that, I think that's the main thing that comes to mind. I mean, I've been incredibly fortunate, and partly why I'm punting on your question or changing my answer. Is that I've just been incredibly fortunate to be mentored by people who are extremely supportive and knowledgeable, and really gave me excellent advice and guidance over the years. Louis Cassingaze, continues to be one of the most important people in my life. And so he basically he's guided me well. And also somebody who gave me that advice, and it was, because when we would submit papers or submit a grant and it didn't get funded, together we would commiserate and go talk. What do we do now? How are we going to respond to this?
After the wine drinking, then back
after the wine drinking,
Yeah. James, thank you so much for the opportunity.
Yeah. No, thank you for inviting me. This was fun.